Okay, Dr. Jochims, that's all that I have, so please take it away.
All right. Hello. So, hypertensive disorders of pregnancy. I got asked to do this one and I said yes, because I just gave a presentation on this about a year ago at our hospital. And so it felt like something I was very comfortable doing. So, hypertensive disorders of pregnancy is a group of conditions that we refer to. It includes chronic hypertension, gestational hypertension, preeclampsia with or without severe features, HELP syndrome, and eclampsia. And I'll kind of touch briefly on each of these. So, next slide. So risk factors. So one of the things I think is important when we're talking about treating and managing these conditions is recognizing who's at risk for developing them. In reality, any female is at risk for developing them, that especially with pregnancy. But nulliparity. So nulliparity is one of the biggest risk factors, and so I think that's something to always keep in mind when you're dealing with this. Multifetal gestations, a history of preeclampsia, both personal and family, chronic hypertension, thrombophilia, gestational diabetes, pre-existing diabetes, BMI greater than 30, antiphospholipid, advanced maternal age, assisted reproductive technology. So your patient's coming in with IVF, which I'm seeing a lot more lately, and sleep apnea. So one of the things that I think I see pretty routinely would be like advanced maternal age, nulliparity, and then the BMI over 30 for sure. Next slide. So elevated blood pressure in pregnancy, what does that mean? So in pregnancy, you're looking at a systolic blood pressure greater than or equal to 140 and a diastolic blood pressure greater than or equal to 90. And severely elevated blood pressure in pregnancy. So this would we talk about those severe features, systolic greater than equal to 160 and diastolic greater than or equal to 110. We'll talk a little more about the criteria for this, but it has to happen when we're talking about the elevated blood pressure on more than one occasion, at least 4 hours apart. However, when you get to severe pressures, we shorten that time to about 15 minutes. We don't really want to be waiting 4 hours to see if that's persisting. And you'll notice that this is different than what you'll see in guidelines from a lot of organizations, which have, for like the general population. We're a little more, I would say, aggressive in treating hypertension in pregnancy. Next slide. This came up. This is something I encounter very, very frequently here, especially when we're dealing with new nurses or different nurses or that sort of thing, stressing the importance of the right cuff. There's a lot of tips and tricks about taking blood pressure that new nurses or everyone in general are, empty your bladder, sit with your feet flat, arm at heart height or et cetera, et cetera. Cuff size is kind of the biggest one that I notice gets kind of messed up. And I will have it go both directions. Sometimes I'll have a nurse say, oh, their blood pressure was a little high, but I put a bigger cuff on and now it's better. And I really stress the importance of, okay, we can't put a bigger cuff on just to fix the blood pressure, but we also do have to make sure it's the right size. Like I have most definitely seen a patient come in with elevated blood pressures, and when I go to see, that cuff is like just, barely touching the Velcro, clearly way too small, and with the appropriate size cuff. So I think that's something the nurses are used to me, both in my clinic and at the hospital, asking now pretty routinely is, was the cuff the right size? Next one. Making the diagnosis. So I cheated. I pulled this out of something, I think from AIM. I think AIM gave us this beautiful little color-coded chart. This slide is very busy. It's a lot of the information. I'm going to kind of run through it briefly, but a lot of this information, this is like something that you should be able to easily access. So I will make a plug in here, the chronic hypertension, the first one. So this is elevated blood pressure on 2 occasions, at least 4 hours apart. So that's essentially the diagnosis of elevated blood pressure. It becomes chronic when we diagnose it prior to 20 weeks. And I will say that I feel chronic hypertension is often missed in pregnancy and not picked up until, seeing some elevations later on in pregnancy. And when you look back in their chart, you're like, oh, you have had high blood pressures multiple times in the past, but a lot of young women or women in general are not getting routine care outside of pregnancy. And so when they show up pregnant, maybe their blood pressure is, 120s, 130s, and we're like, it's okay. And then suddenly it's 140s. And when you look back over the years, it's periodically been there as well. So I really encourage, providers to kind of at even those new OB visits, be talking about, hey, has your blood pressure ever been high in the past? Have you ever been told, that it's borderline high or things like that? Gestational hypertension is really the exact same criteria for high blood pressure, but now they're over 20 weeks gestation when this is first diagnosed. Preeclampsia includes the elevated blood pressure, same criteria for diagnosis on as the gestational hypertension, and the proteinuria, so the protein being spilled into the urine. It's a little interesting. We talk about preeclampsia with severe features. So, what I like to point out is the first line there that says meeting criteria for gestational hypertension or preeclampsia. So, there's a lot of, I think, misconstrued thoughts, and I run into this with providers and patients and et cetera, that if you have gestational hypertension and severe range blood pressures, but you don't have a lot of protein in your urine yet, you're fine. You just have gestational hypertension, which is not true. So even if you don't have protein in your urine, if you're meeting the other severe features, you do have by default, preeclampsia with severe features. So severely elevated blood pressure is one of the most common ways that people, diagnose this or see it show up, but there are obviously a kind of a little smorgasbord of other things. I think the creatinine, it's interesting to look at 1.1 or a double baseline. A lot of pregnant women will run a lower baseline, and my plug for this is to say we really should be getting baseline. So when if you think back to that slide at the beginning that talked about the risk factors for preeclampsia, if patients have enough risk factors for preeclampsia that you're putting them on like a low dose aspirin in their pregnancy for prevention, you should probably also be getting baseline labs. Do they have protein in their urine? What are their liver enzymes? What is their creatinine at baseline? And then HELP syndrome. So HELP syndrome is abbreviation for hemolysis, elevated liver enzymes, and low platelet counts. There, very clearly you can see here there's criteria for development of HELP syndrome. I like to point out this. I was looking for a case and I didn't find it, so I'm sorry. I had a case in the last year that initially she did not have elevated blood pressure. So it is notable that 15% of patients with HELP syndrome lack hypertension or proteinuria. And that patient did come in with nausea, vomiting, and right upper quadrant pain. So next slide. Severe features. So we talked about the blood pressure. So systolic blood pressure greater than or equal to 160, diastolic blood pressure greater than or equal to 110, two measurements, 15 to 60 minutes apart. So think of it as it can be as short as 15 minutes, so they're not sitting for a long time with high blood pressures, but they can be up to 60 minutes apart. So for example, it's 163 over 110, and the nurse says, okay, well, she's really stressed out. We're going to repeat that in 15 minutes. In 15 minutes, it's 149 over 105. And you're like, okay, no longer severe criteria. 15 minutes later, it's elevated again, and now it's again 160s. We've met the criteria now with those two blood pressures. Preeclampsia, basically before eclampsia, what we're working when we manage that is to try to essentially prevent the end organ damage that can happen from preeclampsia, but also prevent it from progression to eclampsia, to the seizures. Neurological signs and symptoms are the best predictors of seizures in preeclampsia. So when I talk to nurses on the floor, like that unrelenting headache, those visual disturbances, those are the things that I want to know about. Like that's something I'm really concerned. If we have a patient with a terrible headache, it's not going away, that's somebody who makes me concerned that they could progress to eclampsia. Let's see, creatinine, these are kind of the same things that we talked about before, pulmonary edema, thrombocytopenia. The things we're worried about with preeclampsia, strokes, seizure, hemorrhage, placental abruption. The creatinine of 1.1, I like to really have pointed out because that's not going to stick out to people that do medicine outside of just like obstetrical care like this, because a creatinine of 1.1 is seen normally in lots of people. So. I might be able to share my screen if you want. Want me to try that?
Yep, sorry, my computer keeps crashing.
See, that's okay. I can try it. Okay, I got to figure out share. Sorry, I'm not as good at this. Okay, we're going to share this. I don't know if I don't know if this is the newest one with the cases. Do you want to work to try to get yours back up for the cases and I'll finish the presentation?
Yes, I can do that.
Okay, that sounds great. Get this shriveled again. Sorry, everybody. Okay, perfect. Okay, so what constitutes a severe hypertensive episode? So a severe hypertensive episode is when there's sustained severe hypertension event documented by more than one blood pressure, just as we talked about. It can occur with gestational hypertension, chronic hypertension, or preeclampsia. There's a formal definition that we talked about and how that can, be construed with not being back-to-back in consecutive measurements. Gestational hypertension and preeclampsia. So we're going to move into some of the management. So if you do not have severe features, but you have gestational hypertension and or preeclampsia, we want weekly monitoring until delivery. So that's an NST and or BPP or NST AFI, the maternal blood pressure checks, symptom checks, and labs. Planned delivery is at 37 and 0. This is something I see come up as debate in my group amongst my partners and some other places as well. Patients saying, well, yes, I have preeclampsia, but I feel fine. Do we really have to do a 37-week induction? I get a lot of pushback from my nurses even because we see a lot of this now. Who are like, oh, dread these like 37-week inductions for preeclampsia and no-lips because they can be long and drawn out. And I always just remind them, the goal is to prevent. It's not to wait till something bad happens and then have to act on it. The goal of induction is to prevent those bad things from happening. With severe features, delivery is typically at 34 and 0, or at the time of diagnosis, which is much of the time if it's after that. Now, sometimes I have seen patients be delivered sooner than that. That's going to be consultation with specialty care, and that's patients who have, very severe features that we're not able to control even in the hospital. Management of chronic hypertension in pregnancy. So fetal surveillance, you're going to get growth assessments on these babies in the third trimester and weekly antenatal testing. Their increased, risk of that placental insufficiency and issues with the placenta that can lead to, growth restriction, abruption, other problems such as that. Delivery timing just depends on the clinical condition. So I really like to point this out. Chronic hypertension, no medications. There's a lot. I think even for a while, I was like, oh, you have chronic hypertension, but you're not on meds. You don't really have hypertension anymore. And that's not really how that works. And so chronic hypertension, no medications can still potentially see a little earlier delivery. Stable on medications, again, very, very wide range. This is pretty patient dependent. And I think a lot of it depends on have you had to increase their medication? Have they been controlled? Do they have other symptoms? And have they developed any coexisting problems? Management of elevated blood pressure. So I think this is one of the kind of important take homes out of this presentation is how do we prevent those things, seizures, strokes, that sort of thing from happening. So this, I'm talking a little bit more, elevated blood pressure is how to like just bring that blood pressure down. Treatment, how do I say this? Okay, this is in the chronic hypertension, the intrapartum, the postpartum. So this is not necessarily talking about the acute severe range. So long-acting oral antihypertensives have been shown to reduce complications. So preferred medications, labetalol, 200 to 400, Q8 to Q12. Max dose is really high. I've definitely sent somebody home on 700 3 times a day. I will say that I often get improved control with labetalol when it's dosed 3 times daily instead of twice daily. I think just based on the half-life, there is a little better control that way. Certainly twice daily is easier for patients to take. And then the extended release nifedipine, usual dose 30 to 60 every daily or every 12 hours, can go up to 120. There's some mixed data on whether 60 to 120 is that helpful. Can't go over the 120. Sometimes I do see side effects of headaches or things with that, but sometimes it's a lot easier, as you can imagine, to take 60 milligrams of nifedipine every night before bed than it is to take 400 of labetalol 3 times a day. Guidelines for treatment is a little interesting, actually. So I think this is something where working with, your local specialist can sometimes be helpful. Chronic hypertension patients that I'm managing in pregnancy, I often try to keep them a little more towards their, target blood pressure of a normal range blood pressure if they're on chronic medication. ACOG, if they've just, developed gestational hypertension and they're in the severe range, this wouldn't really apply, as you can imagine, because now we're talking about different treatment. But ACOG does say for this chronic hypertension that just keeping out of the severe range is reasonable. I suspect that may get pushed more towards tighter control as we see good outcomes. So specifically you can see the CHIP study below here, tight control had improved outcomes. Management of severe features. So the first two things we want to do when we see those severe features. So remember, some of those are lab findings, but also hypertension, unrelenting headache, severe range hypertension, unrelenting headache. The first thing we want to do is control that hypertension. We want to prevent basically hemorrhagic strokes and organ damage. And then the second thing we want to do is we want to prevent eclampsia. So the way we're going to do that is one, treat the blood pressure in a prompt manner, and then two, preventing eclampsia is delivery timing, get them delivered, and then 2, magnesium. So management of the severe features with hypertension. So again, just the reminder of what that is. Labetalol IV, it's given in increasing doses. A lot of times it's, 10, 20, 40, 80, kind of doubling that dose as you go up. There are some instances where it's not as helpful. For example, a patient who's on 400 of labetalol 3 times a day and comes in with severe pressures or features, that may not be the best first line choice. Hydralazine is also available as a choice. There's a little bit risk of side effects with hydralazine. However, there are risks with labetalol as well. It does say to caution use labetalol with asthma. I've definitely used it in patients with asthma. Now, if they had severe asthma, uncontrolled asthma, an acute asthma attack, I maybe would have a lot more caution than the patient who comes in and says, "Oh, yes, I have a history of asthma. I haven't used an inhaler in, 3 years." Um, Time matters. So this is a really important component, and this is something that our hospital has been working on. And we actually just came out with a nurse-driven nifedipine, oral nifedipine protocol, so that the nurse is able to initiate the protocol and give medication to lower those severe range pressures truthfully before they even have to reach out to the provider and let them know what's going on. So far, I don't think that's happened, but they have given it much more quickly than notifying the provider. The provider's in clinic, the provider logs in, finds the patient, puts the order in, the pharmacy approves. So it has been successful so far. But time matters. Treatment should be promptly initiated following that second severe range blood pressure. The goal is to treat within 60 minutes, ideally within 30 minutes. And we're talking about of the first blood pressure. So that gets really tricky if you're, at 11 o'clock, they have a severely elevated blood pressure. At 11:15, it's okay. At 11:30, it's severely elevated again. Okay, now we're already 30 minutes in to that window when we make the decision to treat. So something that you can do to help prevent that delay is if you have a severe blood pressure, even if things are maybe going to turn the other way or something else is going to happen, you should really be starting an IV and probably drawing those, severe preeclampsia labs and/or HELP syndrome labs. Starting that communication with the clinician right away. So I definitely have occasionally had a nurse who calls and says, "Okay, I just had a high blood pressure," and I'll say, "Repeat it in 15 minutes," and they'll be like, "Oh, well, I did. They had one when they first got here. This is the second one," kind of thing. And so in those situations, I definitely would like to know, after the first one, so we can be making steps to be prepared. And then medication is readily available. That's something that's probably policy driven and hospital driven, that sort of thing. And like I said, that's where we recently are working on this nifedipine nurse driven protocol. Um, so this last part just kind of recovers what we talked about in terms of some of your time has already lapsed by the time we make the decision to treat. Measuring the process, this is just a visual so that you can see kind of what that looks like in terms of getting that timely treatment in. And I will say this is something like when we do case reviews, this doesn't seem like it should be that hard to do, but it often is. I think having nurses even set 15-minute, like a timed blood pressure, so it just automatically goes off. Because I think a lot of times they're like, "Oh, I'll come back and check this in 15 minutes." They get busy. It's 30 minutes before that recheck is completed. And so I think that this time passes much quicker than we anticipate it will. Management of severe features, eclampsia. So initial seizure prophylaxis, i.e. preventing the first seizure from happening. So this is when we went back to how do we manage preeclampsia with severe features. We are going to initiate magnesium sulfate. Bolus is 4 to 6 grams. I would say that dosing is typically a little bit weight-based in the sense of using that 6-gram bolus for higher body weights that have a bigger surface area or diffusion area. That initial bolus is given over 20 minutes, and then we're continuing at an infusion of 1 to 2 grams an hour. Number needed to treat symptomatic patients is 36. So there have been studies where they looked at, well, since preeclampsia can become eclampsia no matter what, why aren't we giving everyone with preeclampsia magnesium? Well, that number needed to treat if you have just patients with preeclampsia and no severe features goes up significantly, and you start looking at, a shift in that risk benefit paradigm there. So magnesium should be continued 24 hours postpartum. I certainly have had some oddball cases where we have had to do it a little bit longer. Seizure treatment, supportive care. So when you treat the actual seizure that's occurring with eclampsia, it's really just about making sure mom's getting oxygen, managing her airway, and essentially a baby in utero is struggling as much as mom is. So you really prioritize mom's care. The goal is to resuscitate mom and then proceed with delivery as appropriate, depending on how mom and baby are doing after that. Recurrent seizure prophylaxis. So if they're already on magnesium and they're having a seizure, you can give an additional 2-gram IV bolus. or if they have IV access and they have a seizure, so now, it's kind of the ship has sailed for prevention of the first seizure, you can start that 4 to 6 gram loading dose. Magnesium does not treat seizures in preeclampsia. You're preventing additional seizures. So I think that's something really important to think about. Like when you give that magnesium, you're not essentially, trying to like stop the one that's happening. It should stop on its own. You're really trying to prevent it from happening again. You can give IM magnesium. It's a lot. We actually set up some kits in our hospital, and I learned that based on the dosing and the vials we have, it's actually 2 injections in each buttock. So it's actually 4 shots to do the 10 milligrams IM magnesium. Little slower absorption, variable onset. If you absolutely can't get an IV, then that's an option that's available to you. There is a very big reduction in recurrent seizures and maternal death, like pretty impressive how beneficial magnesium is. And I think this goes to stress the importance of timely initiation of the magnesium as well, not just timely treatment of the blood pressures. Magnesium does come with some risks, though there is magnesium toxicity. There are a few contraindications that we run into. I think one of the maybe more quote unquote common ones to see in true severe preeclampsia might be moderate to severe renal failure. Preeclampsia, severe preeclampsia can certainly affect the kidneys. That's some of the diagnostic criteria. So that is something to definitely keep an eye on. There is a pretty, I would say, decent therapeutic window. There are some protocols that recommend routine testing. I don't know if there's great data on actually routine blood levels, but there is certainly good data on routine evaluation. So having some kind of protocol in your facility where the nurse is routinely checking, often it's reflexes, right? Checking those things. Reflexes are going to be one of the first things to go, followed by respiratory depression, cardiac arrest. Treatment is that IV calcium gluconate, and that is something that should be readily accessible in your hospital. I don't know if it's standard protocol everywhere. It's been in lots of the hospitals I've been in that if you're on magnesium, you're critically ill, you're managing those outputs. You've got a urinary catheter and a Foley catheter. And so one way to manage that evaluation is basically following that urine output as well. Seizures refractory to magnesium. So I used to teach the high-risk OB flight nurses do their quizzes for every year in Colorado, and this was like a really fun one I always liked to do. Is when your patient is on magnesium, seizing, bolus, seizing, you've gone through this magnesium and they're still seizing. Like, what do you not do next, right? So this is the point where you start to think, okay, maybe this isn't just eclampsia. Maybe this is something else. So this is where you get, your ICU, your critical care team involved and head imaging and that sort of thing, and then go down the normal, seizure treatment route. I will point out the ischemic or hemorrhagic stroke. That's something to really think about. I think a lot of my patients that I see, elderly patients with new onset seizure, it has to do with ischemic or hemorrhagic stroke. And we know that with severe hypertension and or preeclampsia, your risk for these things are certainly elevated. So it's definitely something to keep in the back of your mind. Postpartum follow-up. All patients with a hypertensive disorder of pregnancy are at risk for developing postpartum preeclampsia. So it can get pretty ugly. I know that we do a delivery or we do an induction to try to deliver that baby and sort of quote unquote stop preeclampsia, which unfortunately it does eventually, but not immediately at delivery, which I'm sure you're all familiar with. So that follow-up is really important. ACOG recommends patients be seen within 3 days, no more than 7 days. I know my facility is working on this as well, trying to make it just a habit for the nurses to automatically, make those checks occur a little earlier. Fortunately, I think for my practice, we're all FPOB, and we typically are all seeing those babies. So it's pretty great that even if a mom slips through the cracks, she's almost always being seen in clinic with her baby for a follow-up as well. So they do make a point that there are lots of options and ways to do this follow-up check. I'm not familiar with how, all the systems across Iowa are working, but we, with Avera, was able to roll out a postpartum monitoring system, which has been amazing. Patients go home with a blood pressure cuff. It links to the system. It sends blood pressures in. There's nurses monitoring it. And then I get messages if they're having high pressures at home. Patients call me if they're having high blood pressures. It's been a very cool way to monitor them closely from afar. Facility-specific standards of care. So one of the way to meet all these goals and guidelines in terms of making sure everyone who needs magnesium gets it, making sure everybody who needs their blood pressure lowered within 60 minutes gets it lowered within 60 minutes. A lot of the things to help make this happen are, standards of care in the facility, guidelines, algorithms, that sort of things. It really helps to have standard of practice across providers. this ambiguity and confusion is very, very commonly seen here. I think I have providers who are like, well, they're not severe hypertension. We don't have to deliver them at 37 and 0. Or, they did have a high blood pressure, but they don't have any other symptoms. So they were probably just nervous. And so I definitely see, nurses being hesitant to aggressively treat when they feel like they have a provider who maybe isn't a provider that aggressively treats. So, yeah. And I think this might be an old case presentation. So you might want to, oh, wait, this one's in there, I guess.
Before we move on, do we have any questions regarding what we've discussed so far? Hearing none, I'm going to stop the recording.